Morning everyone. Just further to what Jan had to say is back in October 2016 I actually went to an anticoagulation forum in Albuquerque, New Mexico, which was a 2-day boot camp. It was hard work, but it wasn't physical, fortunately. And also spent a day with one of their anticoagulation pharmacists at the local University of New Mexico hospital. So it was actually very, very useful for me because anticoagulation was one of my first scopes of practice as a pharmacist prescriber. But when I came back, I thought we need to do something in New Zealand to get people that are interested in anticoagulation together to share our knowledge and experiences, and so today's been born out of that idea 18 months ago. Thank you, Jackie and Matt, for the introduction, and we're going to move on to a few further topics now. And this is one of the questions that the haematologists in Wellington probably get asked quite a lot, and it's to bridge or not to bridge. So when might we consider bridging, apart from when we might be initiating warfarin and we're in that initial 5 to 10 day period where there isn't a therapeutic INR, but there may be a question around whether it's necessary perioperatively and the immediate post-operative period. We also raise the question of if someone's got AF and there's a high risk of stroke, do we need to actually bridge then? And also those patients that have got heart valves and they may be with AF, they may be subtherapeutic, but also they may also be going to surgery, the surgical situation. So 1 in 10 anticoagulated patients might need an invasive diagnostic procedure or surgical annually, and we also know that for warfarin it's got quite a long half-life, and that's one of the advantages of the newer agents, that they don't need to be withheld quite so long before surgery. But conversely, after the surgery it takes a good 5 to 10 days to become therapeutic again. And we also can see here that the relative risk for thrombosis after surgery is in that first 3-week period after surgery. And it would also depend on the type of surgery and how immobile they are after surgery, because we do know that people that have had, not even had surgery, but have had broken legs and things and are relatively immobile because they've got full-length plaster casts on. And if anyone has been in that situation, you don't like moving around too much because they are heavy, then they are always at risk of developing a VTE. But at the time after surgery and the weeks go by, that risk diminishes. So if we look at the first slide on the left there, if we have a break in the warfarin, then that risk of thromboembolism is through that, potentially, hypothetically, in those days prior to surgery and immediately afterwards while the warfarin is being reinitiated. But on the alternative side, if we were going to give some bridging therapy with a low molecular weight heparin and then afterwards, that risk would be diminished quite significantly. That's the theoretical risk. So the idea for bridging therapy would be to reduce the risk of thromboembolism and prevent those outcomes that we don't want to happen, like stroke or DVT, valve thrombosis. But any excess bleeding risk of the low molecular weight heparin would be offset by the risk reduction of actual clot. So back in the 2000s, the American College of Chest Physicians did a meta-analysis of studies that had evaluated patients stopping warfarin for elective procedure, and some had received molecular weight heparin and some hadn't. And what did they find? That when they collated the study results, there was a slight favour in bridging with a reduced number of VTE events. But when they went and looked further, when they assessed the outcomes of bleeding, that all these 5 studies here, they noted that the major bleeding, it actually favoured no bridging. So this is something that we really need to stop and think about. So their recommendations were that if the high-risk VTE, they suggested bridging during the interruption of warfarin therapy, and this would be assessed on the patient, the risk of the surgery and things, and we'll talk a bit about that later. But if they were low risk of VTE, that no bridging. Moderate, well, jury's out. It would really be the patient. And again, it would be dependent on what Jackie's already talked about, which would be have they had previous VTEs in the past and that sort of thing, as well as their transvac scores or their HAS-BLED scores and things like that. So later on, the same group sort of did a retrospective study of 1,812 procedures on warfarin, and this was from over 6 years, and they found that bridging therapy, 75% was treatment, 25% prophylactic, and some had no bridging at all. And then they looked at the clinically relevant bleeding, whether there's something VTE occurred or there was any death. And what they found was that, again, the bridge therapy was associated with high rates of clinically relevant bleeding. There was virtually no change in the risk of a recurrent VTE. So they recommended that bridging was unnecessary in the majority of these patients. So this is just a quick little flow chart. So this is what sort of that suggests to us, without adding any of the patient factors in, that if it's a low risk surgery, no bridging. If it's medium risk, consider bridging, and high risk, recommend bridging. And then we do have low molecular weight heparins or heparin infusions, depending on what sort of patient it is and how much cover you might need prior to surgery. Of course, those with metallic valves and things were probably more likely to be on a heparin infusion because you can stop it sort of a few hours before surgery. Discontinue at 24 hours and 4 to 6 hours for your heparin infusion. So what about those patients that they're not just maybe at risk of VTE, but they've got AF as well? So the bridge trial did a randomised double-controlled trial, and the AF patients were looked at, and some were randomised to a low molecular weight heparin prior to their surgery, after their warfarin had been stopped, and some were just given a placebo injection. And the warfarin was stopped 5 days prior to all procedures. So this is just a diagrammatic version of what I've just said, but you can see here then that dalteparin was the low molecular weight heparin that was used, and it was stopped the day before surgery, and then post-surgery, and while the warfarin was being restarted, they were given low molecular weight heparin and warfarin. Now this was the resumption of that anticoagulation was done. If it was a low risk of bleeding type surgery, it was done with a 24-hour period, but if it was a high risk, it was done at 48 to 72 hours. And the study outcome was that bridging or no bridging? Well, that's the question. Again, there were small differences in the number of VTE or stroke between the two, but major and minor bleeding was significantly different to the placebo group if those received the bridging with the low molecular weight heparin. They also looked at later about what might be some of the predictors of bleeding, and bridging was at the top there, of course. Congestive heart failure, it's an interesting point. A high-risk procedure, an INR above 3, or we would potentially think that might be a problem. Aspirin use and post-op procedures. What about a patient just with AF? A patient's got AF, but do we bridge when we initiate warfarin? Or we don't need to, we know with dalteparin we don't, Dabigatran we don't. But back in 2000 when this was published, it was dalteparin versus aspirin for bridging an acute stroke in patients with EAP. Certainly they reduced the amount of recurrent stroke with a small difference, but again, if they were given dalteparin, the composite outcome, whether it was recurrence, progression, death or intracranial hemorrhage, was higher with bridging. This is a later study looking at bridging therapy, and you've got 3 groups there. You've got some that had or 4 groups, some that had no bridging, some that had bridging therapy, some that had low molecular weight heparin alone and oral anticoagulant alone, and the actual survival function is actually higher for those that didn't receive any form of bridging at all. So this is the one that says none, is actually the control group. So a few little messages coming along here, isn't there? For those with mechanical heart valves, it's hard to have a study with someone with heart valves because you don't really need, for those people that have already got mechanical heart valves on warfarin on warfarin, you don't really want to give them a placebo, for example. So their recommendations were that if it's a high risk, they classify the heart valve to low, to high, moderate and low. But there's very, very little data. And certainly most people with mechanical heart valves that are on warfarin and they need surgery, if it's a major surgery, then they will be put on a heparin infusion prior. They will be on low molecular weight heparin in the community, potentially a heparin infusion, depending on how long they have to wait in hospital, and then they'll go back on a heparin infusion after the surgery. So, do we still bridge? So, yeah, the current recommendations, though, that if they've had a history of VTE during interruption of warfarin, or they've got a low INR, and certainly those that have a mechanical heart valve, they have a low INR, and we're looking at a higher INR therapeutic ratio, then we will bridge with a low molecular weight heparin. Patients that have had acute thrombosis within the past month, high risk DVT PE patients, and those with high risk surgeries, and those with heart valves and AF. So what are the options? This is a busy slide, but there's plenty of options. So here we've got warfarin interruption with no bridging at all. Start up to, could be up to 5 days prior to surgery, and then reinitiate 1 to 2 days after surgery, depending on the bleeding risk of the surgery. Theoretical ideal bridging would be this. So uninterrupted oral anticoagulation, so the patient continues taking warfarin right up to and we'll talk a little bit more about low risk surgeries and when that might be appropriate shortly. We could have uninterrupted but just a slightly INR, full heparin bridging, low dose heparin, post-procedure heparin, again delayed post-procedure heparin, early transition of heparin, or nothing at all, but we use compression devices or something like that. And this is the new oral anticoagulants where you can stop. This one's got prior to surgery, but dependent again on patient's renal function, the type of surgery, how many days that may be withheld for. And someone that's got chronic renal disease and is on Dabigatran may stop their Dabigatran maybe 4 or 5 days prior to surgery. Probably a little less than that. Do we need to stop warfarin at all? Some of these are procedures amenable to uninterrupted therapy. And tooth extraction was one that you mentioned, Jackie. And we had a stroke patient on warfarin because she had a mechanical heart valve, who we re-warfarinized and got her back to therapeutic INR, and then had her teeth out with a therapeutic INR. The whole lot came out, no problems at all. That's not to say that it couldn't go awry, because there's always going to be those people that will bleed within the normal therapeutic range. But it just goes to show that there's quite a lot of things that could be done without actually stopping any anticoagulation.
We don't interrupt anticoagulation for bone marrow biopsies anymore.
No, and I think for carotid endarterectomies, they don't even stop the clopidogrel anymore. So the theories, it's changing. The thoughts are changing quite significantly.
I think sometimes surgeons have different ideas.
They do indeed, yes.
I mean, in our area, they pretty much stop warfarin for just about any surgery. We end up having to bridge with low molecular weight heparin from sort of minor surgery lists and all sorts of stuff, and you think, oh God, and it's so much work buggering around, getting organised, and sometimes you wonder whether it's needed, and perhaps when you put up a list like that, you start to wonder.
There are some quite good lists of what's considered low-risk surgeries and this sort of thing, so you can sort of categorise the type of surgery.
You could write back to them and challenge them on that, and actually list some of this, that actually this is a low-risk surgery. The risk of them having a problem from the bridging is greater than the risk of them having from bone marrow biopsies. You one or more holes in the back of your PSIS, no bridging. Doesn't matter what you're on, no bridging. We just do it.
And as you say, it's harder to get them.
Guidelines, wouldn't it, these types of things, because it's often the surgical registrars who are doing it, and they may be a bit nervous and stuff, and they don't have any guidance, particularly in a I come from a provincial area with a smaller.
Our endoscopists have just decided they don't want to bridge, which is kind of, we looked at all the bridging for like years. They've got minor risks of bleeding. So we're looking at what we can kind of get rid of.
And further to that, we've seen people that have been off their warfarin waiting for an endoscopy in the community, and they've stroked waiting for the endoscopy. So, you know, that is the risk, that if it's going to be several weeks.
What about aspirin? Because that's what we get asked all the time when you're practice. You know, they're having some skin biopsy or some little thing. I mean, we tend not to worry. So does the same apply for a lot of this? Because surgeons get very twitchy about aspirin as well. You know, and that's quite common.
I would only stop aspirin if it was really critical where you're operating and where the bleeding is going to be. So, you know, and also if you're going to stop aspirin properly, you need to stop it probably about 10 days in advance. So people who stop aspirin a couple of days before is irrelevant. So you either need to do it properly in advance or not bother with it at all. So neurosurgery, you know, that, and where it really matters if you get a bleed, kind of epidurals, things like that. But then it's got to be taken on the risk of the patient as well.
There are different reasons to do it.
So what about the DOACs? And so this slide just sort of summarises that with Dabigatran, if they've got really good renal clearance, that it may only be necessary for 1 to 2 days, but if it's poorer renal clearance, then it may be, to get it fully out of the system, maybe 3 to 5 days. Now, of course, if you've got life-threatening surgery, then we can use our reversing agent, and we do that on occasion. It's not just a life-threatening bleed. If they've had a fall or whatever and they need to go to theatre quickly, thrombin time tells them they've still got some Dabigatran on board, then we will give the reversing agent, and that does happen. And that's why the surgeons, we give the surgeons that approval, because we don't have haematology on call. And I'm sure Matt doesn't want to be rung at 2 a.m. in the morning if he's on call. To say, can we give Prexbind?
There's only 3 New Zealand Blood Service registrars, and so we've got New Zealand Blood Service, you're on call 1 and 3 for 24 hours.
Yeah.
It's reasonably taxing if you get one phone call, you know.
So that's why we made it. So the senior medical officer, the surgeon, or an ED consultant gives that call, and they sign the form that gets faxed to us. So we keep a track of all of the Prexmine users. They have more trouble finding the Prexmine than actually wanting to use it. Apixaban, so that's low risk breathing, just 24-hour stopping prior to surgery. It's a higher one, 48 hours, and rivaroxaban, just 24 hours. So there are some advantages of these newer agents over Dabigatran, but of course, if someone's on rivaroxaban and they need urgent surgery, we still don't have that reversing agent available. Dabigatran, for VTE treatment, they say there isn't bridging per se. The recommendations from the trial said 5 days of low molecular weight heparin, stop that, then start Dabigatran when the next dose is due. Although I don't know what happens in Wellington, but some of our consultants don't feel that that's absolutely necessary, and they might only do it for 2 or 3 days. Some of them might not even do it at just over a 24-hour period. And then restart within 24 hours. And rivaroxaban, restart when the next parental dose of low molecular weight heparin was due. Apixabans would be the same. Reversal agents we've just been talking about. No reversal agent for rivaroxaban yet. Not yet. The trial was underway, and this is just yesterday. I got an email from the Anticoagulation Forum in the States on their newsletter, and the Adexonate alpha has been approved by the FDA for release to certain people early June for more availability early next year, with a black box warning that it might cause stroke and it has a cardiovascular risk, which is obviously what's going to happen if we're going to reverse some anticoagulation. But it is a modified decoy protein, binds to the factor 10A inhibitors, so it actually negates the effect of the 10A inhibitor, so it works quite quickly, again a bit like the Prexmine does. It binds to the active drug itself. So again, just another little useful decision tree, adding in that oral anticoagulant, and then you've got your high risk surgeries, your low risk surgeries, but also we need not to forget that we might have high risk patients.